All right, I'm seeing the numbers go up. We'll give a little bit of a buffer for folks to trickle in. Welcome. All right, as people continue to trickle in, we're just going to get started. I want to first and foremost thank you all so much for being here for the launch of this report and what we hope will be a super important resource for the field. The report is called Maximizing the Impact of Nutrition Interventions with Local Food Procurement. My name is Kristen McEnroe. I am an attorney and a clinical fellow at the Food Law and Policy Clinic, which is part of the broader Center for Health Law and Policy Innovation at Harvard Law School. And before we get started in earnest, I would really like to thank the Rockefeller Foundation and the Builders Initiative for their support on both the report, this webinar, and also just the incredible work that they're doing in the food as medicine space. Rockefeller Foundation actually committed to investing over $100 million into improving healthcare outcomes through the adoption and scaling of food as medicine throughout the U.S. healthcare system. So with that, it's my pleasure to introduce Noah Cohen-Klein, who is Director of Food at the Rockefeller Foundation. And Noah's going to give us some introductory remarks to get us started.
Great. Thank you, Kristen. And thank you, everybody, for joining today. If you are on this call, then you probably play some role in the growing movement to establish food as medicine as a standard of care. That is, to integrate healthy food into healthcare as a treatment that can be clinically prescribed and paid for by our healthcare system. And if that vision comes to pass at scale through our healthcare system for everyone who is eligible to receive food as medicine benefits like medically tailored meals and produce prescriptions, then it will be a multi-billion-dollar market for food purchases. And today's conversation looks at how we can set up that multi-billion-dollar market to drive economic growth by prioritizing, to the extent possible, local food purchasing from small and mid-sized farms, from underserved farmers, and from farmers using good, resilient agricultural practices. So this emphasis on local sourcing is one of our priorities at the Rockefeller Foundation. We're really excited to see Chilpy's new report, which shows how some states are already prioritizing local purchasing and community-based food as medicine implementers in their food as medicine policies. And it also elucidates the policy pathways, the investments, the actions that are available to states who wish to do the same. I've read the report multiple times, and it is a great resource for advocates, for coalitions, and for folks in government who are seeking not only to improve health through food, but to drive economic growth for their farmers and for their local and rural economies as well. To that end, at the foundation, we also support a cohort of food as medicine organizations that are making strides in program level and farm level innovation that connect their food as medicine programs to farmers, and are also supporting their evaluation to better understand, better describe, and better message around the impact that this local sourcing has for farmers and for their food system. So with that, I'm thrilled that a few of the folks who I admire as leaders in this work are the speakers on our webinar today, and I'll hand it back to Kristen to introduce them.
Thanks a ton, Noah, and thank you again to the Rockefeller Foundation and to Builders Initiative for the support and just the amazing work that you all are doing. So I'm super, super excited to introduce you all to our panelists for today. I'm going to start with Heather Latino, who, in addition to really spearheading this report and being one of the loveliest colleagues ever, is an attorney and a clinical instructor at the Food Law and Policy Clinic at Harvard Law School. We also have Erin Martin, who is a gerontologist and founder and CEO of FreshRx Oklahoma, which is a nonprofit food prescription program that's been operating in North Tulsa since 2021. And we also have Tom McDougall, who is a founder and CEO of 4P Foods, which is a public benefit corporation that launched in 2014. And that organization operates as a food hub network throughout the Mid-Atlantic. So super excited to have you all here today. And before we kick off with the panel discussion, I'm going to turn it over to Heather for just a brief overview of, why Chilpy decided to write this report, what it covers, and get everyone started for the discussion. So thanks so much.
Thanks, Kristen. And I just want to echo the appreciation for all of you that are here with us today, taking an hour out of your afternoon on a summer day to learn about the report that we issued. And also just my appreciation for Tom and Aaron, who joined us today, along with Noah. I have so much admiration for their work and their passion in this space, and it's really infectious. To talk a little bit about why we did this report, for me, I kind of go back to this fact that, for me, food as medicine has become this really incredible success story. We have two of the states that first began implementing food as medicine programs who have had evaluations of their work published in this past year. And those evaluations are really remarkable. Earlier this year, researchers published an evaluation of Massachusetts's Flexible Services Program, and that's the program that provides nutrition interventions in partnership with community-based organizations. And those researchers found that there was a 23% reduction in hospitalizations amongst participants. They also found that for adults who were enrolled in the program for more than 90 days, healthcare costs went down. It more than covered the cost of providing food as medicine, and it even resulted in some new cost savings. That evaluation came on the heels of an evaluation of North Carolina's Healthy Opportunities pilot, which provides food as medicine interventions through their Medicaid system. And it found that after 8 months of running that pilot, that the program was generating a net cost savings of more than $85 per participant per month. So we're increasingly recognizing the impact of food as medicine on the healthcare system in terms of improving healthcare outcomes, its potential to reduce costs. But there hasn't been as much focus or attention on the intersection between food as medicine and the agricultural system, which is where the food is coming from. And as Noah mentioned, this is really important because as food as medicine programs scale, millions of dollars, potentially multiple billions of dollars, is flowing through state healthcare systems to fund the purchase of food. So there is a real market opportunity for US-based farmers and producers at a time when we're importing more than half of our fruits and more than a third of our vegetables from overseas. And so we're seeing this opportunity to invest in local communities, to boost employment opportunities, to support US producers. And the goal of the report was to talk about food procurement and to compile some of the policy tools that can be used to imbue food as medicine programs with food systems values that are important to the states and communities that are designing and implementing these programs. So before I jump into what the report covers, I want to do just a little bit of level setting. I just used the word procurement. First, what do we mean when we say procurement? Procurement is just a fancy way of saying purchasing. And when we talk about procurement policies in the report, what we're talking about are the organizational guidelines that standardize purchasing decisions. And that can encompass lots of different considerations, from how many bids might be required to what price might be paid, to the types of standards that an organization will consider when they're making purchasing decisions. And there are different rules when you are using private funding, as many food as medicine programs have been doing in their startup, versus when you're using public funding. And so we wanted to really explain the differences between those two systems and the rules that can apply when you are purchasing goods or services with government funds. So though organizations that are using private funding can set whatever policies they want, when you're bringing in government funding, and you're a government agency, or you're an entity, or you're a contractor that is using those funds, there are specific rules that can be implicated depending upon the source of that funding. So whether it's coming from the federal government or the state government or local government, and those rules around spending can be set by legislation or by regulations. And so in the case of Medicaid, we have this blend of funding. Some of it's coming from the federal government and some of it's coming from the state government, which means that rules at both of those levels can be implicated. And those rules might prescribe or set specific requirements about how those purchases must be made, or it might restrict what can be done in that purchasing space. And one of the things that I think is important to understand is that kind of in this procurement space, traditionally, we've set up and had the system where vendors that supplied the lowest cost goods, in this case food, were typically awarded government contracts, even when those costs might fail to account for other externalities like environmental harms or economic benefits like increased tax revenue to a particular jurisdiction. But over time, there's been this evolution of procurement law, and it's really developed to factor in some of these considerations. In the food purchasing space, preferences for local foods are a well-established example of values-based procurement, and that's why we chose to focus our report on local food procurement. But states and governments can incorporate lots of other values, and they may not be prioritizing local food purchasing specifically. They might instead or also be prioritizing small businesses or ensuring environmental sustainability. So the goal and our hope is that people reading this report will use the discussion of local food purchasing preferences as a jumping off point to consider what local food procurement requirements apply in their jurisdiction or vendor preferences or other values their state may have that should be integrated into their design of their food as medicine initiatives. So in talking about what the report covers, it's really broken into 3 sections. The first section covers procurement basics, so some of the things that I've just been talking about, but goes into also some of the flexibilities that have been built into the Medicaid system that allow states to set programmatic goals and to be innovative in this space. It also goes into depth into the strategies that have been used to promote local food purchasing when you're using government funding. Then we discuss how to connect food as medicine to food systems goals and strategies through government policy, procurement policy, and that's really the heart of the report. We've tried to pull together different examples and opportunities and places where values can be integrated into food as medicine initiatives and the policies that guide those initiatives. And we tried to give concrete examples of what states are doing to promote local food procurement or the use of community-based organizations. And then we wrap up the report with some recommendations for states and community partners that draw upon the incredible work and examples that we've seen from advocates, community-based organizations, and policymakers across the United States. And just to give you a sense, and because the report focuses on local food procurement, I want to illustrate just one of the ways that state laws can preference the purchase of in-state or local foods when state agencies or their contractors are spending state funding. In our research, we found that there are 12 states that have mandatory price preferences for the purchase of in-state foods or agricultural products when state agencies are using their government funds, their state government funds. As an example, Hawaii requires a 15% price preference for in-state agricultural products. And what that means is that even when Hawaiian-grown foods cost up to 15% more than that exact same food from another state, the state will purchase the Hawaiian-grown food. So if you're in a state, one of these 12, that has a law that requires a price preference for foods grown in your state, you should be working with your state officials to see if these preferences apply in the food as medicine space. And even if they don't strictly apply, working to align the food as medicine policies and strategies that are being used with the monetary value your state has placed on local food purchasing. There are lots of other ways that states preference local foods or vendors, and we talk about those in the report. And we also include an appendix that details state local food procurement laws across the country. And we hope that this will be a useful tool to spark some of these conversations about what local food purchasing requirements apply or what values your state has in this space. But ultimately, the goal of the report is to make sure that as food as medicine programs are being developed or they're being scaled, that we're not just looking at it through a healthcare policy lens. We're not just looking at it through a local food procurement lens, but we're bringing in agriculture and food systems policies, perspectives, and values to build a food as medicine initiative that is thinking about what food is going to be provided, how it is grown, where it's coming from, who's growing it, and how much is being paid for it, so that we are building initiatives that align with our state values. With that, I'm going to pause. I feel like you said brief, and I'm worried that that was like a little beyond brief, and I'm really excited to be able to like have a discussion with the other panelists today. But thank you, Kristen, for giving me the opportunity to get us started with a little bit of background.
Thank you so much, Heather. I think that was a great overview, and I think it just lends itself to me encouraging people to read the report. It is very, very rich with technical details, but it's also incredibly full of just amazing examples and also practical takeaways and recommendations. So I think you did a great job. We could have used the whole hour for it, but I'm really excited to transition into the panel discussion. And since you've had a chance to give a little bit of an overview about the report, I would love to turn it over to first Erin. I really want to hear more about kind of the origin story of FreshRx Oklahoma, and in particular, why does FreshRx Oklahoma make local sourcing and regenerative agricultural practices such a priority within the provision of these food as medicine services?
Great to be here, everyone. The report is really incredible. I think I'm frozen, but hopefully you can still see me. The origin story of FreshRx is during the pandemic, obviously there was a lot of things being highlighted, what food insecurity, one of them chronic disease, and a lot of cracks in our society that had been there for a long time. And there was a doctor in North Tulsa, and North Tulsa is a very low income area, food desert, didn't have a grocery store for 14 years, highest rates of mortality from diabetes there, actually about an 11-year longevity difference between North and South Tulsa. And as a gerontologist, that really disturbed me. And this particular doctor said, my patients are compliant in their prescriptions and their doctor's visits, but they're getting worse, and it's the food, and I would like to prescribe food. And can you help me do that? And I said, absolutely. And there was kind of a community committee putting this together and said, okay, we'll just source the food from Walmart or Amazon. Well, funny enough, after I completed my master's in gerontology, I completed about an 8-week course in soil advocacy through a nonprofit called Kiss the Ground that had us read a lot of soil science around nutrient density and how much our food had been incredibly depleted from nutrients by the way we have farmed over the last 50 to 100 years. And I was really amazed by its ability to not only restore the nutrients in food, but actually be able to increase it. And especially if it's local, it'll maintain those nutrients more. And then I thought, even from an economic standpoint, we want to invest in local economy. Why wouldn't the funders want their money to stay in the economy and go further? And so I said, I'm not going to source from Walmart or Amazon, and I'm going to source from all local regenerative farmers. And they thought I was a little crazy. And they said, you're not going to be able to do that probably at scale or year round. And I love a challenge, and I proved them all wrong. And it was really fun doing it. So we have very close relationships. We've served about 27 small scale growers and some hubs within 200 miles, and it's become more hyper local as we've scaled, and the farmers actually outscaled us. So I'll probably talk more about later how we've supported them in diversifying their markets as well.
Amazing. Yeah. Thank you so much, Erin. I love the idea of just seeing the opportunity to get this positive feedback loop going, and really, yeah, taking on that challenge and getting it started. So, Tom, a similar question for you. I want to know a little bit more about 4P Foods. I know you place a priority on good food, and you also really focus on creating access to markets for underserved producers and also producers who use regenerative agricultural practices as well. So I'm curious, how and why did 4P Foods get involved in food as medicine to begin with? And how has that shifted or maybe enhanced your mission over time?
Yeah, sure. Thank you, Kristen, and thank you everybody for making this webinar and this discussion possible. To build on what's already been said, so 4P Foods is what the Department of Agriculture might define as what's called a food hub. I think maybe we'll talk a little bit more about that a little bit later. But in short, we buy food from local and regional farmers, and we create new markets for them, and we deliver it into multiple different channels, with food as medicine being among them. When we got into food as medicine, I don't think we had the word for it, but our mission 11 years ago when we started was and is the same as it is now, which is really these two pieces that we hold in harmony with one another. With the first piece being focused on the supply, like how can we build a new business model, a new marketplace, a new system that can enable small and mid-sized farmers who are stewards of our land and our soils and our waterways and our rural communities such that they can thrive, which is an intentionally different verb than where a lot of them are right now, which is kind of barely survive. And we can go down a whole sort of historical context of what it has meant to be a small and independent farm since really the early 70s in the US. Or we can go all the way back maybe 400 years and talk about sort of our overall economic system and how it's been built on extractive models of agriculture and enslavement of labor and so on. So part one for us is like, how do we center the stewards of our land and ensure a marketplace that can help them thrive? And part two was and is and continues to be, as we do that work, how do we also ensure that we're building an equitable food system? How do we work with partners to enable a world where everybody, regardless of income, race, age, zip code, has equitable access to good, healthy food that is of their choice, that nourishes not only their bodies, but also our planet along the way? Which like gives me all the warm, fuzzy feelings to say out loud, right? It looks good on a PowerPoint. It is very hard to make that look good on a profit and loss statement. And anybody that's in the world of procurement for any sort of institution can understand that tension that exists in that, like, well, how do you do that? How do you, in fact, pay farmers the right and proper price for producing nutrient-dense food, but also all the other services that they're providing by being stewards of the land, like sequestering carbon, increasing biodiversity and biomass, storing and retaining water, driving rural economies, like pay them the right price for that, but then also serve everybody, and especially including those in marginalized and oppressed communities at price points that work for them, which 10 times out of 10 is going to be less than what you just paid the farmer. And this price gap is the manifestation of a broken system, or a system that's working as it was designed, perhaps more accurately, but it is to say a system that's worthy of redesign or re-architecture. Because that gap is why food deserts exist. It's why food apartheid is real, and it's why we have the cardiometabolic disease epidemic that we have in this country. And those two things are so interrelated. All of which is a long answer to say that, like, it was our mission 11 years ago. We didn't have the language food as medicine, but we sure did have indigenous wisdom from thousands of years telling us that food is in fact medicine. We now have a name for it, which has been more helpful for us internally and working with partners of like, oh yeah, like produce prescription programs delivered from local farms. And that has given us the ability to really like lean into that as a core part of what we do and what we exist to serve. And it's been a really powerful orienting point to sort of prove that, not only to Erin's point, like farmers are here for this and they are ready, willing, and able to scale. But also, like, this is not really a new idea. It's something that we're sort of bringing and breathing life back into in terms of more local and regionalized supply chains. And there's a lot of merit to it, which I think we'll probably talk more about.
Yeah, I think you touched on a lot of both what people are asking in the chat and then as well what we're going to get into shortly, which is, more about the implementation of your programs and also how do you build that evidence base? How do you make the case for what you all are doing and explaining that price gap and why it's worthwhile in terms of, the impacts to the soil and the environment and the people who need this food. So thank you for giving another rich answer, and we're going to dive more into detail. So now I want to transition a bit into, as I said, kind of the implementation focus. So back to you, Erin. I'm just curious more about kind of the structure of Fresh RX Oklahoma and how it operates. So that could be, I know a lot of people are curious about how that money is flowing from a Medicaid system to a program and then ultimately to, food to people who need it. And then I'm also curious specifically about the partnerships you all build with the Oklahoma producers and the value that's stemming for both the organization and then also the producers themselves.
Absolutely. So we have a 12-month program. It's a produce prescription program. The participants enroll. We get referrals from providers, or people can self-refer as well. We do an enrollment process. They're enrolled. We get initial health metrics, and we start them, and they go every other week or receive delivery. We have a hybrid model, both in-person or delivery. They get about $50 worth of fruits and vegetables, local and regeneratively grown. It's done like a multi-farm CSA. So we're aggregating from maybe 6 to 10 producers every other week. And on our off weeks, we're also aggregating for the Muskogee Creek Nation's Indian Health Services. So we drive to 5 rural cities as well. So people get about $50 worth. They come through like an open crate model so people can have some dignity of choice, but it's a curated amount of offering. There's usually probably 8 to 12 different types of items that people can choose from. And they have a cooking demo or an education class right there. And then every 3 months, we're measuring A1C, weight, and blood pressure. And we really had to curate these farmer relationships very carefully. In Tulsa, we don't have a food hub. And so I really had to build a food system from scratch. And so I started at the farmers market. We have a great farmers market in Tulsa. And I really found the producers using great practices. And I asked them lots of questions. I found 3 or 4 of them. And then I turned over stones and got referrals through other farmers that maybe weren't at the market, but do other maybe CSAs. And really built this network of growers who wanted to grow for nutrition. And it was really beautiful to meet all these really younger farmers, which you don't see. The average age is like 60 something of farmers in the US, and lots of young people who had been really called to quit their 9-to-5 corporate job and become regenerative farmers because they wanted better food for their families. And it was reinvigorating for them to have a market to sell into that they knew was healing people that really needed it. And so that's been really amazing to watch people, participants give testimony, farmers give testimony, and doctors give testimony, and farmers being valued for the quality of their produce over quantity. We have really sacrificed a lot by focusing on quantity over quality and focusing on the size of our house instead of the foundation. And we have built incredible close relationships, and we evaluate what their needs are. We do farm visits, and we see where they are, how long they've been growing, what their practices are, and verify those practices. And then we connect them to support. And so Conservation Commission, the conservation districts, the NRCS, getting them funded for hide tunnels to diversify their crop production or increase their crop production, getting them access to soil health improvement plan grants, diversifying their markets so they're not overly dependent on us, and doing 50% upfront contracts to buy bulk purchasing to support them and not having to take all the risk on their own. And so really investing in them as much as we do our participants. And I had a funder tell me one time, do you mean the patient education is as important as those farmers? And I knew I had done my job finally in educating the funder on that. And that was really exciting. And so they are the success and the quality of the food and the local food economy is as important, and it's inextricably linked to long-term change for people, and to have that food more widely available for the community. And we've done that, and we've stimulated that and killed two birds with one stone, so to speak. And there's no reason why we can't scale healthy, beautiful, local, regenerative food on the back of food as medicine. And I think we have the duty to do so.
It's so powerful to hear, and yeah, I have so many thoughts, and I want to respond so deeply, but I want to move on. I want to make sure that we can hear from everyone. So I'm going to transition to Tom and just ask kind of again a similar question, more of the operational lens of 4P Foods and how food hubs really fit into this space. I think we had a question in the Q&A that maybe we can weave into this as well around, in really rural or remote locations, maybe how can food hubs fit into something like that, where farmers are really looking to find a market but don't necessarily have access, and again, just emphasize the relationships that you all have with local producers as well would be great.
Yeah, absolutely. And I just want to like plus one everything that Aaron said, and in the context of like in rural places, I have a lot of conversations with folks like Aaron where it's like, I don't mean to spoil it, but like I think you accidentally started a food hub. If there is no food hub, start a food hub kind of thing. Although I'll come back to that. I mean, maybe I'll begin with like in the early 1970s, the Secretary of Agriculture, Earl Butz, famously said, "Get big or get out," to the American farmer. And it was well intended, and it was followed up quickly with, like, plant fence row to fence row. Like let's reduce the what was perceived as drudgery of farming by increasing the amount of food that each individual farmer can produce, to free up our youth to move to cities, to get educations, to pursue other professions, to serve us as doctors and lawyers and dentists and whatever it might be, right? Um, and so we did, right, so we did. So began the centralization of the production of food, and then soon behind it, the production of food scaled into larger and larger farms. So too did our processing of food got larger and larger in more centralized places. So too did the distribution, the consumption, right? The whole sort of food system shifted in the decades following the beginning of growth. Um, and food hubs back then were a thing. Farms would bring their produce or food or wares to their local or regional distributor, and there were thousands of them in every nook and cranny of the United States. And they would then in turn deliver to the grocery stores and restaurants, of which there were also thousands of them. But as all of those industries consolidated, so went away a lot of the small farms, a lot of the processors, and a lot of the distributors, which is why the USDA redefined that role of like local aggregation and distribution, aka a food hub, in 2010. And per the USDA, a food hub is a business or an organization, so for-profit or nonprofit, that has four primary functions in the form of aggregation, storage, marketing, and distribution of source-identified local and regional food. Any USDA folks on the line, I hope I'm doing you proud. And the key part is that local and regional part, right? In our American supply chain right now, the vast majority of our fruits and vegetables, over 60% of them, come from one valley in California, because we've designed it to be really efficient and very large in terms of production. Correspondingly, though, food changes hands on average 7 to 12 times before the average consumer receives it. Here on the East Coast, the average tomato is 3 weeks old. It's harvested green usually, it's transported across the country, it makes its way to a distribution center, usually along the 95 corridor, where it's gassed, and that gas helps to turn it artificially red so it looks good, but it has the nutrient density, profile, and taste of a green tomato because it's effectively what it is. Meanwhile, the farmer in that supply chain, because it has changed hands so many times, makes somewhere between 12 and 14 cents on the dollar. Now, juxtapose that with a food hub, right? When we started our food hub in 2014, there were 70 something food hubs in the country. Now, and this is 3-year-old data, but 3 years ago, there were somewhere between 450 and 500 food hubs in the country. In aggregate, we are collectively buying from somewhere in the neighborhood of 30,000 smallholder farms. We've not reached every nook and cranny of rural America, but there's 3 food hubs in Hawaii alone. There's several in Alaska. Like I know we're pretty deep. But I'll add the caveat that there's sort of this tongue-in-cheek nomenclature in the food hub nerd communities that I'm a part of. That like if you've seen one food hub, you've seen one food hub. We're all a little bit different. We all come in different shapes and sizes. Um, but in our world, typically the food goes farmer, us, customer. And so we've collapsed that supply chain. And in so doing, we transfer the economic power back to the farmer. So in our world, our farmers are paid somewhere between 60 and 70 cents on the dollar. We've also created a tremendous amount of transparency in terms of where the food comes from. Shorter supply chains mean that that tomato can be harvested when it's red because it's harvested yesterday and delivered tomorrow. And in a medical setting, we could and should and will have a whole conversation around nutrient density and putting up a red tomato versus a green tomato. We could talk about price per milligram in terms of nutrients as opposed to price per pound, which is weighing water weight. We're not there yet scientifically, but we're getting closer. And the food hub world plays that really important role of connecting because farmers are excellent producers of food, excellent stewards of their land, and food hubs do a lot of work on the operations side with aggregation and distribution. But they also act as a bit of an educator and a translator, as Aaron was talking about, to be able to like open the doors within healthcare systems and create those partnerships that ultimately represent markets for our farmers. And I think what's exciting to me, at least, is there's a growing conversation again in the nerdy food hub world about creating a national food hub ecosystem of some sort, whether it's through informal cooperation, which is already happening at lots of different regions, potentially up to and through like national associations, so that in calls like this, someone's like, hey, I'm interested in sourcing locally. Where's my local food hub? You got to Google it or like call me and I'll put you in touch with some folks. But we're not terribly far from a world where the local and regional food system is ready, willing, and able to serve the national healthcare system.
Yeah, thank you, Tom. I think both yours and Aaron's points really, I think, emphasize just that the desire, the need is there, and it really is about building those relationships and connecting the dots. You know, again, this isn't a novel idea, but I think you both are definitely putting the pieces together to move it forward. So thank you for both those remarks. I want to transition back to Heather now and just you did give us such a great overview of the report and encourage people to read it again and again. But I'm curious, could you give us some highlights of the states that have already started to integrate local food procurement into their food as medicine programming, and maybe give a little bit of a brief summary of how they actually did it? And again, maybe it'll encourage people to go and dive in deep as well.
I'd love to, Kristen. Thank you. So, you talked a little bit earlier that there were like some early implementers of food as medicine, and kind of amongst those like early implementation states, we didn't see language in the food as medicine policy documents that were being issued and kind of setting up these programs that was talking about local food. But that has really changed in the past couple of years. And so I want to talk about 3 examples from all different parts of the country. The first one is Hawaii, which was the first and so far the only state that when it applied to the federal government, to the Centers for Medicare and Medicaid Services to ask to be able to cover food as part of their Medicaid program, they put specific language in their application saying what they were planning to do. And what they said was that in implementing food as medicine, they were going to encourage the inclusion of local growers and community-based organizations to, quote, support the purchase of locally grown food and support Hawaii's intrinsic food system. So very explicit, like goal setting and language around what their priorities were going to be. We moved to the center of the country, Michigan, not in their 1115 application, but instead in policy guidance, is how they chose to like talk about local food preferences. What they did was, again, indicate that they were going to have a very strong preference for locally based providers. And what they did was actually set a benchmark or a mandate that 30% of the services that would be provided should be provided by locally based providers in the contract year 2025, and that they envisioned that that percentage would go up over time. And what they did was they defined locally based as both having a physical presence in Michigan, but also participating in Michigan's local food economy. So another really fantastic example. And then one of the more recent examples that's due in part to the advocacy of Erin and her partners and colleagues at the Food as Medicine Coalition that has been at work in Oklahoma was to get language into Oklahoma's recently passed Food as Medicine Act, where Oklahoma is directing the state agency to seek permission from the federal government to provide coverage for food as medicine supports. They were able to get language into that legislation explicitly saying that whenever it's feasible, we envision that you, state Medicaid agency, and the entities that you're contracting with, the Medicaid plans, should prioritize the inclusion of community-based organizations and local growers to support the purchase of locally grown food. So like 3 really fantastic examples from all different parts of the country. There are lots of other policy levers that can be used and ways that states can support local food systems through, and community-based organizations for that matter, through their Food as Medicine initiatives. And we describe those in the report. We also have an appendix at the end that describes like the different policy levers that can be used, what types of opportunities they present. And then we give the examples of the explicit quoted language that each of these states has integrated to either lift up local food procurement or to lift up the use of community-based organizations.
Thanks, Heather. And I'm so glad you mentioned kind of the advocacy that was going on in Oklahoma. I think we were all super, super stoked about that. And it's a great pivot for me to turn back to Erin. As Heather mentioned, in May, the Oklahoma legislature passed the Food as Medicine Act in Oklahoma. And I really want to know more about kind of why it was so important to you at FreshRx Oklahoma and the Food as Medicine Coalition to have that specific language around local growers and community-based organizations in that legislation, and just more about kind of the nitty-gritty work that was being done in advance of that passing.
We founded the Food as Medicine Coalition of Oklahoma at the end of 2023 with the help of the technical assistants from Chilpy at Harvard, Erica and Heather. And we have about now 150 members across the state of Oklahoma, across universities, community-based organizations, healthcare, our own healthcare authority that governs Medicaid, all of our managed care organizations, tribes, and people really passionate about the local food system. And so we have a really diverse group of people, and we honed in on what our vision, mission, and goals were for the coalition. And one of the 3 main goals was prioritizing local community-based organizations and locally grown food. And this was something that we all really agreed on, the vast majority of us, 70 to 80% of people. Some people probably didn't understand, or maybe it didn't apply to them, or they didn't really know. But this was something we really agreed on. So I wanted to put a lot more into the law about what is local food. There's a lot of loopholes that could be moved around in there, but at least it's in there. And I was really lucky to be able to review and edit the bill with a legislative analyst from the state capitol. And I actually got to write that language in the bill. And there was no pushback on that. There was actually very little pushback on this bill. All the stars aligned, and we had 5 unanimous votes, including 4 committees in the Senate on this bill. And the final vote was 76 to 8. And we were able to, with the help of Erica Hansen, I was able to prep the House author on the outcomes from North Carolina's cost savings, from Massachusetts, and we were able to get that through really easily. There were certainly questions about fiscal impact, and we were able to clarify those things and worked in tandem with the healthcare authority to help answer a lot of those questions. And so we were intimately involved with that process. my co-lead, Lauren Larson from Hunger Free Oklahoma. We both worked diligently, both together and separately, tag teaming, making sure we were talking to all those committee members and making sure that they really understood. And we didn't have much of a challenge, to be honest. It is in alignment with what people want on both sides of the aisle, what certainly our current administration wants. And people were very excited about this. And our governor and our lieutenant governor were also equally excited about this. And so that was the hill I was willing to die on, was including local food and really honoring community-based organizations that have the trust of the community, that are actually doing this work, and that we should figure out how to prioritize them and how to all work together and make sure the good grassroots work that's been done, both on the local food system side and the CBO side, is honored and it has a place permanently at the table. And so at least there's language to back that up.
It's amazing, Erin. You said the stars align, but I think it's really a testament to the work that you all put in and the many, many other community-based organizations that, as you said, have already been doing this work, and the need and the desire is there. So kudos to you. And yeah, so excited to see where that goes in Oklahoma. And Tom, I think Erin touched on this a little bit, but that evidence base, building that evidence base, making that case for moving this forward. I'm really curious about the efforts that 4P Foods is putting into building that evidence base, determining metrics of success for local, regional, and regenerative food distribution. I know we heard a bit from Noah as well about the cohort research that's going on. So I'm curious from 4P's perspective, what are you all doing to build that base?
Yeah, sure. Thanks to support from the Rockefeller Foundation and others, we're doing exactly that. For example, one of the projects is a 3-year endeavor to assign some quantitative values to these things that we think we know intrinsically, like, yeah, local food is better, right? But like, what does that mean? That's too squishy to turn into some sort of law. So here in Virginia, I'm on the Virginia Agribusiness Council, and Virginia is a very pro-farming state. So, but we don't have yet 1115 Medicaid waivers, and food is medicine. So we are measuring right now what is the economic impact of using food as medicine, and specifically a local food procurement strategy associated with it, as an economic driver for jobs in the Commonwealth of Virginia, with a specific look at some of the rural jobs that right now are either threatened or going away. Because if I am a policymaker here in the Commonwealth, I'd want to know the answer to that. Because if you, as Erin saw in Oklahoma, right? Like, if you're telling me that we put a mandate in for, say, a 15% price premium for Virginia food, but we can increase the state revenue because the number of jobs that are created, the state local economic multiplier effect, tax basis revenues being increased, we can actually pay for that 15% increase and create healthier community and people within the Commonwealth. And regardless of the side of your aisle that you're on, that makes a lot of sense. But the burden is in proving that. So this report that was recently launched, thanks to Chilpy, is a wonderful baseline for that. And then spending the next several years really starting to measure and evaluate with our partners in North Carolina State, what's the economic impact, and then separately but related, our friends over at the Rodale Institute, our measurement and evaluation partners on this project, to measure the environmental impact of this. What does it mean to have shorter supply chains? What does it mean to have food that's grown and using more regenerative practices? And what are the positive overall resiliency outcomes that can come with that? Which is a whole separate sort of dialogue and conversation that's also warranted when we look at some of the research that suggests that in the Midwest, our currently most productive cropland in the United States has approximately 30 harvests left on its topsoil before it can no longer produce food in a way that's sustainable. We're talking until about 2050, at which point the breadbasket of the United States is going to be done producing food. So what's plan B? I think investing now in local and regional food systems is a really healthy and optimistic plan B that can be a win no matter, again, what side of the aisle that you're on.
Thank you, Tom. Yeah, I think that's great. And again, just points to the need for making that case, but really, again, it's already happening. And I think we're seeing more and more efforts in that direction. So it's great to hear the work that 4P is doing. Heather, I want to give you a chance to just talk a little bit more about kind of the most impactful avenues that you see stakeholders taking to integrate local food into food as medicine interventions. And then we're going to transition over to Q&A because there's been a ton of momentum in the chat as well.
I'll keep it short. I think as you listen to like Aaron or Tom, or you hear about what's happening in other states, it can seem really aspirational and maybe like hard to figure out, like, but how do I actually like accomplish this thing? And so I think really the most important thing is to know that one of the things that we tried to do was to kind of create a toolkit or a roadmap that folks who are on this call who are interested in these issues can use, that walks through like what we've seen. It's not my ideas, it's like what has been done across the country. And so, you know, like if you're interested in this and you're a community-based organization, forming a coalition like the one that Aaron and Lauren have been leading in Oklahoma, that is bringing together like all of these perspectives and really developing like a shared mission and shared goals that they can then advocate for, you know, like outlining just like the different steps in the process where you can act or integrate or work to kind of bring these policies to fruition. And one of those like sets of recommendations is really geared towards like state policymakers and agencies. And then the other one is geared more towards implementers and community-based organizations. And so I'm hoping that that is a useful tool in kind of figuring out like, how can you be most impactful in creating policy change?
Yeah, thank you, Heather. And I do think the report really covers such a wide array of, you know, members of the audience, whether it's a community-based organization or a government stakeholder. So I do think it really meets people where they're at as well. I want to give you all time to answer some of the questions from the audience as well. So I want to kick off with one. Again, we're trying to consolidate some of the questions that we've received. And one of them was, you know, the state of the current research regarding nutrient density and soil health and how that really interacts with the research more generally about the efficacy and quality of food as medicine interventions. So I don't want to assign that to someone, but if someone feels compelled to kick us off, that would be amazing.
I could take a crack at it because this has been a learning curve for me personally, with like a little bit of context that I grew up in a farming community and farming family, and the farm that I worked on in my childhood failed and it got sold off, and what was my backyard as a dairy operation is now a golf course, and like so I come to this with personal passion. And so I was the one that was incorrectly stating, yeah, no, like we know that food grown using regenerative practices is in fact more nutrient dense. Um, and it turns out like I think that's true, but we don't have yet enough research to say that unequivocally and emphatically for policymakers at a federal level to like green light that thing. But it sure does look like that might be the case, right? So we need to stay the course on continuing that, which is where I think like this discussion and this like early days of what is food as medicine by way of local procurement is only in part possible because of funders like Rockefeller and AHA and others. So thank you. But like the next step of you working with states and having them come in and take what are often start as like tiny little pilots because one healthcare provider cares and somebody else is crazy enough to do it and whatever, like that then needs to go to scale. And that's where there's sort of this parallel track of like continuing the rigor around the science and the studies to prove some of these big ideas that we think will be the case. And if they are, they're fundamentally game changing for two of the top three systems in the United States are military, healthcare, and food. We're talking about fundamentally shifting number 2 and 3 together. So let's stay the course on the research and working as a community in a Zoom call where there's 300 people that care about this kind of thing, I think is both exciting and relevant to the fact that like this is a whole systems approach. So all the scientists out there, please stay the course and prove what we think is right.
I think we know that if something has more nutrients in it, we're going to be healthier. I think that's a very basic thing to understand. I think there's a lot of great groups working on data. We need more data, like Tom said. I think we can start to tease apart, and I think we're going to see benefits of both, of the freshness of local, maintaining that nutrients, and how much more nutrients regenerative practices are producing. And what we do know is that the average age of fruit or vegetable is 14 days old in a grocery store. And the USDA knows and says that it loses 10% of its nutrients every single day. So there's not anything left in that thing based on that information. Not a whole lot of some of those nutrients. And I still think we don't understand all of the layers of nutrients and what they're associated with in general, which is why projects like the periodic table of the elements of food is so vital, and the work of Audacious and the Nutrient Density Alliance and Bionutrient Association and Stefan von Fleet and all these other folks. We are going to start seeing more evidence of this. And this is critical. And just like Tom said, if we continue to source food through food as medicine programs that are extractive in their systems, we won't be having a food as medicine conversation anymore.
Yeah, thank you both for that. And I think to both your points, more data is always better. But I think we know a lot intuitively already. So as Tom said, stay the course and make that case. But I think this is kind of a general question for everyone, just given this discussion and a lot of the conversation around cost considerations for food as medicine interventions in light of recent federal program cuts. Now, what does this mean for the landscape and really making that return on investment pitch to those who are paying for these services? Again, don't want to assign it to someone, but the brave soul, whoever you are, will kick us off.
I think it's a great question. We've talked a little bit about like some of the evidence base that exists. And I think part of that evidence base is the impact of reinvesting like state funds back in the local economy. And there is good research and evidence on the multiplier effect. Like as those dollars are spent, they are like continue to circulate in the local economy, which creates benefits for like the feed store, the grocery store, like other businesses that are being utilized in that community. But there's also a multiplier effect on employment in that like those dollars like also help to create and fund employment opportunities for people who live in those communities. So there's a really good evidence base that I think means a lot and is really important when you're talking with state policymakers and legislators. I'm not sure, like outside of like kind of appealing to that at the state level, like, how we are going to navigate the loss of some of these programs and funding that has supported a lot of the infrastructure and capacity building and efforts around local food procurement. And I know that there are questions that have come in the chat around that, like, we had great funding streams that were really helping to provide technical assistance and pay for local foods to get them into school systems, and great research showing the economic impact of those programs on communities. And how do you now pivot with like the loss of those programs? I think I think there's like some hope that perhaps other funding streams may be created to fill the void. But there might also be a need to shift to like thinking about like other places for those funds to come from, or as Noah's doing and Tom is doing and Erin's doing, continuing to develop the evidence base for why this is so important. So that we have like the evidence to be able to explain to policymakers who are making those decisions, like why this is really critical and actually more beneficial than thinking about it in the short term.
Thank you so much, Heather. And it pains me to end it here because there are so many really good questions in the chat. And I want to encourage folks, if we didn't get a chance to answer your question live, please feel free to reach out to myself, other members of the Center for Health Law and Policy Innovation team, and we will try our absolute best to get you answers to those questions. I want to thank you all again so much. I want to thank our panelists, Aaron, Tom, Heather. I want to thank Noah for the introductory remarks and the whole Chilpy team for the support on this. Thank you all to our audience for joining us. And I did want to preview that there will be a survey once the webinar ends. If you have the time and can spare your feedback, we would love to hear it to make this better and better. And thank you all again for your interest. And thank you to our panelists. Thank you.
Thanks, everyone.